In this video, we are going to discuss about neonatal hypoglycemia. Right, neonatal hypoglycemia is a very important topic as far as neonatology is concerned. Often the most frequently tested topic in our exams as well. So let's start with this topic: neonatal hypoglycemia. Neonatal hypoglycemia. Before we begin this topic, you should know what all infants are prone to develop hypoglycemia. A small baby has less stores, so would be more prone to develop hypoglycemia. A large baby has more demands, hence more prone to develop hypoglycemia. Right? A preterm baby similarly has more chances of developing hypoglycemia. Right? When we talk about neonatal hypoglycemia, it is termed as blood sugar levels less than 45 milligrams per deciliter. Right? This type of hypoglycemia, this documentation could be associated with some symptoms that is known as symptomatic hypoglycemia, hypoglycemic symptoms, or it could be asymptomatic. Baby is appearing well, but you notice these low levels of blood sugar. So when we talk about managing these babies, the management depends whether there are symptoms associated with this hypoglycemia or the baby is asymptomatic. So this could be either symptomatic hypoglycemia or it could be asymptomatic hypoglycemia. What all symptoms can we see here in the neonatal population? We can notice that the baby is jittery, or the baby can have some seizure-like activity, or the baby could be lethargic, poorly accepting the feeds, right? So let's talk about the management now. Asymptomatic hypoglycemia. The management here depends on the absolute value of the blood sugar that we have got. If the values are somewhere in between 20 to 45 milligram per deciliter, then we ask the mother to feed the child, right? We give a trial of feeds, right? And then after feeds, we again reassess the child and note down the blood sugar levels, right? But if the baby has less than 20 milligrams per deciliter of sugar, now you don't wait for giving feeds and reassessment. These are very low levels, right? So you straight away start with IV dextrose. We give IV D10, 2 ml per kg bolus, 2 ml per kg bolus, followed by a glucose infusion rate, a continuous glucose infusion at 6 mg per kg per minute. 6 mg per kg per minute. Similarly, with symptomatic cases, you now don't wait for the trial feeds and reassessment. You straight away give IV bolus followed by glucose infusion 6 mg per kg per minute, and too early you are going to now monitor the baby. Depending upon the blood sugar levels, you can now increase or decrease this glucose infusion, right? I can go up to 8, 10, 12. This is the maximum. After that, we try other agents like glucagon and octreotide. That's it for the management of neonatal hypoglycemia.